But I'll just introduce that. So my name's Lee Hampston. I'm the Development Director for Safe at Home, and we're part of KCOM. So I have two roles within the organisation. My primary role is to deliver, and I'll use the word IP, digital technology-enabled care. For me, analogue and digital are quite, in the environment that we're in, we've moved on beyond there. I also look at future technologies. So what I'm looking at is 5 or 10 years down the line, when we make certain investments, what is the infrastructure, what are the products and services we're going to deploy on this new infrastructure, and how's it all going to work? KCOM itself, we're a large communications integration provider in the UK. We used to be known as Kingston Communications, some of you may have heard of that. Probably more known for being KC and Hull, where there is no BT, there's no cable and wireless. We are the only telecoms operator in there, and we also have cream telephone boxes, so we paint the cream, so we are different, so we're a unique island. That sets us challenges, but it also allows us to do things slightly differently around technology, because we own the infrastructure and we can do things in a much more quicker and agile way. Safe at Home, the business unit that I run, can harness the group's assets. So the KCOM group provides everything from huge cloud solutions through Amazon networks. We do work for DWP, HMRC, Bupa, huge managed services, right down to Johnny Haddock's fish and chip shop. And we also have about 160,000 consumers in East Yorkshire. So huge organisation, huge footprint to play with. What I'm going to cover today is two areas. The first bit is around what's called exponential technology advancement. So what happens when you start looking at medical and technology advancement on the current thinking on the ageing population? What does that do to it? And then starting to link in a little bit more on what the technology platforms are that are going to help support that. And I think, as I said earlier, fantastic to see that you'll hopefully see some similarities in the kind of like architecture and the solutions that we're putting forward to the vision that's shared in Scotland. So, very straightforward question, and you don't need to answer because I hope we'll all agree with that, with the actual outcome is. I guess everyone in the room agrees that the elderly age groups of the population are projected to increase the most over the coming years. I think no one will disagree with that. So I think we're absolutely in agreement with that one. If you look at the high-level statistics, and they do vary from different areas, 11 million people over the age of 65 currently, 1.5 million over 85, and 15,000 super centurions. There's about 1,000 super centurions, so 110 plus currently in the UK. I guess if you bring it more locally to Scotland, and I was quite surprised by some of these statistics. Between 2010 and 2035, those aged over 75, and this is from your NRS records, an 82% increase of the over 75, which is a significant increase. Also, your centurions, 820 currently, that is going to increase to about 7,600 by 2035. So you've got, there's a huge swell of the ageing population group, and the charts on here just basically showing that this increase is actually happening. What I've said is what starts to happen then if we start building in technology, both from a digital environment, a computing environment, and a medical environment. What happens to that ageing population? So in large enterprises and in government, I don't know if anyone's heard of Ray Kurzweil's prediction analysis. So it's a tool we use to allow us to predict historical trends or future trends of exponential growth in technology. And it's quite a proven model to do it. So where are we at with current technology advancement? If I go back 5 years, you can safely say a computer would increase its processing power every 5 years, and you get a new development out, and that's where it's at. If in this 5-year curve, we're probably in 2012, you're now at the actual threshold where every 12 to 18 months, technology is changing. So you're now starting to see mobile phones coming out every 6 months for you with better processing power, better storage, better connectivity. So that's starting to happen. We're already into this curve and we're into 2016. So your 12 to 18 month acceleration of technology is changing yet again. So we're now probably sub 12 months where technology is changing month on month, and that can be anything from medical science, medication, technology. It's developing at that rate. Okay. If I also look back 5 years in my industry, we had the convergence of IT, telecoms, and data networks. And those three camps said it'll never happen. You know, they tried blocking it and stopping it. Sure enough, it happened 2 or 3 years later. You've talked about it, all came together to work as one platform. We're on the cusp of the wave of what's happening now in healthcare. So you're now starting to see your telecare, your telehealth, your telemedicine, your security systems, your smoke systems, door access will converge into one platform. And all that information and all how it's going to work will become relevant. So that convergence of technologies is happening as we speak. You've already got cloud-based e-health platforms out there. So we're in this curve here, predicting and working, albeit in silos, working in demographic areas, but not communicating across a broad spectrum. One of the interesting things which I kind of didn't pick up is digital technology, is e-cigarettes. So what you think, well, what's e-cigarettes got to do with this? But you start to think about smoking is around 100,000 deaths per year. I'm not sure how many long-term conditions associated with smoking, but significant amount. The initial findings which we're seeing on e-cigarettes are suggesting it will have a beneficiary to the individual. So what happens if there's 100,000 people don't die and we reduce the long-term conditions? That's just one technology that could increase the population rapidly. And that's one technology we know about that only happened, 2 or 3 years ago. It became mainstream. Does anyone know who Foxconn is? So Foxconn are Apple's manufacturer of hardware and devices. And about 2 weeks ago, or roughly, they laid off 60,000 staff and they replaced it with artificial intelligence and robots. So the most advanced, probably, Internet of Things provider has now replaced the workforce, and they're now putting artificial intelligence and robots in place to manufacture it. What does that mean? Well, artificial intelligence will start to scale down. So it starts at the highest level. Within this 5-year curve, probably more into the 10-year curve, that will start to be adopted in the home, in the workplace. There's another piece, and I think we've talked about it there, is when you go into hospital, no one tells you there's Wi-Fi there. We don't market things very well. But what we are missing is that marketing is going on all around us. I know through my in-laws that when my daughter goes there, she's educating them on technology. She's making them comfortable around technology. And there is a myth around elderly people won't adopt technology. We have deployments of smart tablets in many thousands of properties where we can't stop people developing those services themselves. They're now video conferencing each other in 3-4-way video conferences. They're sharing information. So that myth is broken and needs breaking. There's another interesting when you start to look at the medical information. Dr. De Grey, who's the Chief Scientific Officer for Sense in the United States, is saying, on average, each year, an average of 3 months to the life expectancy is happening currently. So that's just with medical advancements. They're also predicting that there could be around 1 million super centurions in the world by 2030 with these medical advances. So that's kind of like starting to show you really where we are now. We're in that life cycle, it's happening. But then what happens when you start to move up to a 10-year window and you're now moving away from hundreds of times advancement to thousands times more advanced? So we're accelerating the way we can develop technology. Where it starts to change is in the planning and the budget thinking, and what you need to do is, what you have to start doing is investing in future-proof platforms has to start happening now and into this 10-year curve, because when we're talking a little bit about what this impact is, if you wait until 2029, and we know that 2030 the aging population is going to balloon, that's it, you're not going to be able to play catch-up. So the investment in platforms has to start happening now. You can no longer start, and Tom alluded to it brilliantly, tactical decisions on 1960s technology cannot happen. You've got to start moving away from that technology, because if not, you'll continue to put in budgets, year-on-year budgets, and not looking at a 5 or 10-year budget. We wouldn't do that as a business. We'd look at a 5 or 10-year plan and build it around that one. When we go into health organisations in England, I just, the fact that they say, oh, well, we've got to spend the money in the 12 months is crazy. They don't forward plan, and this is part of what we need to transform. Again, I alluded to Foxconn. The most exciting advancement in this 10-year curve will be artificial intelligence. So you will find in the home there will be robots and artificial intelligence helping people to live in their homes much longer. And why it will happen is quantum technologies and computer technology will start to develop. So what you'll start to have is a computer or a robot that will be able to go around the house and identify specific objects. So it'll have the capability to identify that's a bottle, that's a glass, pour it in, deliver it to the individual. That in 10 years is reality, and that will start happening. So you can see where that scale is. Potentially you could reduce the amount of care needed by face-to-face and start to do that. But it will start to happen because people will adopt it. The other thing which we've talked about next door is digital inclusion. Next generation networks will start to transform how services work. And as part of my other role, in Hull, by 2020 there'll be no copper in the ground. We'll have ripped all the copper out. Every single property will be fibre to the premise. So we've made that tactical decision to do that. But what that then also leads for me to then is well, what if we've got fibre into home? What's the capability of that fibre optic? I know that in Afghanistan, in the kind of for the MOD, they use fibre optics to listen to vehicles and movement of enemies to actually find out what they're doing. We've been testing that, so we can actually now start to listen on a fibre optic. You can actually hear a mobile phone paging. You can actually hear footsteps in a room. You can actually start to see temperature changes. You could hear somebody falling. So your traditional sensors and telecare sensors that we know has been white boxes will probably vanish in that 10-year curve towards the back end of it. And there'll be just simple little devices that will detect what is going on. And we are already looking at how do we actually adopt that service. And that's very, very soon that'll come along. Homes will be connected, so people will be building homes that will be fully connected. They'll be refurbishing homes that will be fully connected. And in that, towards that back end of that 10-year life cycle, every single thing in this room that we're in will be connected. So when you sit on a chair, it'll know you sat on the chair. You'll probably have some form of technology that tells it's you that sat on that chair. This is where it will go. You'll start to see computing technology, and I think you alluded to a pill that somebody takes. You'll have in-body sensing in 10 years. That will happen. There'll be a chip in your body that will sense. It won't be like a digital tattoo, which is really there, or smart wound dressing. They'll be inside the body. They'll monitor vibration, movement, temperature, fluids, and they'll be signalling constantly what's going on. And I guess one of the biggest changes is it will no longer be in the domain of big enterprises to deliver this. So your KCOMs, local governments and universities won't be doing this. It will be down to small innovative companies like Communicate. They're the key to transforming this, and you need to get 7-10 of those companies together to develop this technology. They are the only people that are going to create a paradigm change needed to deliver this 10,000 or this 1,000 times advancement. So it's absolutely critical. So where do we go from here? In 20 years' time, we will be developing technology 1 million more times advanced than we are now. So if we look at this the past 16 years, or 14, 32, it looks pretty flat. It's a 4,000 times advancement. But as we start to move forward, this is where the actual advancement really starts to happen. And what you'll start to see, you'll be buying regenerative medicines off Amazon for £200. There'll be brain interfaces that you'll be able to buy. They'll tell you what you're thinking, why you're thinking it, triggering how you're going to be depressed. These type of technologies will start to be available. Artificial intelligence will be caring for us in our home in this life cycle. You probably will, if you have the choice, you will have a carer come into the home if you need it. You will have nanobots in the body that will be detecting and eradicating disease. That will start to happen. So, this is where it starts going. The acceleration of life expectancy starts to happen in this life cycle. So this is where you realistically talk about somebody living to 150 years old. It will happen in this life cycle. What's more worrying is in 40 years. So 40 years, hopefully I'll be 85, I'll still be living, but I might have the opportunity, when technology demands, to actually have some decisions around how long I live. So what will start to happen is quantum technology will be advancing minute by minute. So people will be developing new technologies, new services, but at the homes. It'll be that. It's hard to believe, but it will happen that quickly. You'll start to see the quantum tech will start. It'll lead to radical life extension. So this is in 40 years' time, you'll be able to choose whether or not you do live to 150, or the reverse is you'll have euthanasia on prescription because potentially people won't want to live to that age. So Logan's Run, the crystal in the hand, all that thing comes around to you. You are creating a problem for the future, but at some point there's going to have to be that demarcation. How do you stop this happening? And then how are you going to support, in 40 years' time, this acceleration of the ageing population? And ultimately, what does it really mean? So just high level, if we start to look at the current statistics, 11 million aged 65, 1.5 million over 85, 15,000 centurions. The standard predictions that are currently out there suggest by 2030 there'll be 16 million over 65s, 3.4 million over 85s, 60,000 centurions, and probably around about 2,000 super centurions. So that's what's currently being predicted now. What I haven't built into any of this is what happens with medical science and how that develops. But if we built a 20%, 30% increase that technology will increase life, you're then starting to move into 20, 25 million over 65s, 3.64 million over 85s, 75,000, 90,000 centurions, probably 30, 40,000 super centurions, and even to thousands of people that are going to be 100, 150 in that area. So you've got to start thinking about this now and putting the platforms in place that are going to cater for this, because if not, we will get caught short with what's happening. I guess the other thing is, why wait until 2030 to start doing anything about this? Why incrementalise? You know, the usual model is, well, in 2029 we'll do something about it, 2030 will come, we start again. And that is what is currently happening. For me, healthcare, I see it being so far behind the consumer revolution, it's frightening. You know, you go and buy any healthcare device off Amazon now, you're all wearing, or most people are wearing Fitbits and information that's communicating. If I pull a muscle when I'm going running, or I don't go to the doctor anymore, I go on YouTube and learn how to use kinesiology tape on my body. So that consumer, we've got to somehow stop tinkering with technology, stop incrementalising, and actually get healthcare to be like Amazon, where you can actually buy it online and it just becomes very, very simple. I think the other thing again is the terminology we're using. We talk about telehealth, telecare, telemedicine. We've got to move away from that. It's not. It's kind of like health. You know, I like to say it's hospital home of the future is where we've got to get to. So we've got to start changing the language. And the reason I say that is my father-in-law is part of the Rotary Club, and I've been going on the Rotary Club doing presentations on technology-enabled care and some of the devices. 85% of the audience did not realise that this technology was available to them. They thought it was for people on social care allowance, those types of stuff. So they didn't realise it was even available. So that whole marketing piece about how do we get this out there is going to be absolutely key. And again, you know, we're all talking about video conferencing. Well, fantastic. Video conferencing is so naughty. It's from year 2000. It's on Skype. We shouldn't be using Skype. You know, it's not supported. You can't record, but there are platforms out there. These step changes and revolutions we've got to make and move away from the current thinking. So, it was fantastic that we started to talk about the infrastructure and how this is going to work. Because without this infrastructure being put in place, you might as well forget everything we're talking about around technology-enabled care, because unless we connect people, it isn't going to work. So, you've got some fantastic projects going on. Digital Scotland, Superfast Broadband. You've got the Scottish Wide Area Network, the SWAN network, which is very similar to the Health and Social Care Network in the UK. What we're trying to do is the Health and Social Care Network in the UK connects doctors, surgeries, GPs and hospitals. The next step is to actually take it to care homes and individuals. So it actually becomes part of that network. But what the challenge really here for me is actually why, you know, the statistics there was it 42% of people don't have the internet in the ageing population in Scotland, somewhere in that area. Why don't they have it? Well, they maybe don't want to surf the internet, but why should that be a barrier to connect them? And that's the key, is the connectivity. Why can't you come up with a health tariff? You've got the SWAN network, you've got the Superfast programme, we've got satellite going out there, you've got wireless, you've got mobile, whereby they pay £1 a month just for an access to a health network that transfers the data of all these telecare devices. That's got to be achievable. We're looking at doing that in Hull. I want to do that in Hull. We need to start pushing Ofcom to actually look at deploying it. But why from the top in Scotland could you not drive this and say there's a health access, £1? And that would potentially give you ubiquitous coverage to everybody to start deploying your technology. I've already mentioned in Hull 2020 the copper's gone, so that'll happen. everything will be working over the internet protocol. All the technology that we're putting in is internet protocol based. Does anyone know what happened in Wales when the digital 21CN network went in and was turned on? The Telecare stopped working, basically. And that's happening all over the UK. Because, BT, their priority is not delivering that, it's delivering a service. So this type of signalling that is going on within Telecare will stop working at some point. So this is one of the other reasons why you've got to start moving into this environment. And I know that BT will start to move their strategy from fibre to the cabinet to fibre to the premise, because they've just stolen our engineering director who led the delivery in Hull. So they will absolutely start looking at that strategy going forward. The other interesting view for me is current technology versus new. The legacy equipment that's currently out there, Tom, again, 1960s legacy equipment, it absolutely is. Some of this equipment will be going, they've been in there 15 or 20 years and it's still in there, ticking over. You've got the limitations of the copper or analogue network that allow this to work. It's a reactive service. So you press a button, it goes to an alert receiving centre, the individual then takes the alert and then may do something around it. So it's very reactive. We need to start thinking about how we make it more proactive. It's localised. So you've got multiple arcs in local areas. We're talking to some of the London boroughs where they've got 18 boroughs. Each of those boroughs has an alert receiving centre. They could just have one. They could save significant amounts of money, capture all the data and learn out what is going on. Instead of 3,000 people, 50,000 people. So there's a key thing is if you're starting to think that is alert receiving centres at scale, 1 or 2 across the whole of Scotland, absolutely fantastic, would deliver what you need. And there's a stigma associated with a lot of this old technology. We've done some discussions and surveys with elderly people. Good 20-30% of them leave those pendants on the bedside table and won't use them. They don't work outside the home, and a lot of people don't like pressing a red button because what could that mean to them? Well, they're going to hospital, they're going to a care home, they don't come out. So there's a definite stigma associated, and it's good to see Doro, some of the devices that are going on there are becoming more like jewellery, more like trendy, service. It's fantastic. But where's it moving to? So, digital IP technology is an enabler for the future. It's about building a platform. The platform could be a localised platform, or it could be a regional platform, or it could be a UK platform that delivers healthcare or telecare across the UK. It integrates into health, housing and social care. It's absolutely fundamental it does this. So we've got all these fantastic alerts going on in the alert receiving centre, but we're not learning anything about what they really mean about Mrs Smith's movements around the house, and how it links to telehealth and how it links to Ready Records, because the systems don't talk. So we need to start linking those systems together. We need technology that works inside and outside the home. So they're not restricted to the home. We don't want to, we want to keep people in the home for longer, but we need to let them get out of the home. It needs to be proactive. So this is the key bit around why should a smoke alarm go to an alert receiving centre when actually in Humberside that goes straight to the fire brigade, and they analyse what's going on, and they understand that actually 85% of smoke detectors are actually toasters with a depress it, deactivate it. That's one thing they're looking at. Why couldn't the temperature sensor go off and go to a community navigator locally where they could deliver a heater or a blanket? So the power of IP technology allows you to deliver alerts to anywhere in the world as opposed to an alert receiving centre. We'll move on a fraction from there. So think of this, and you've already alluded to it, as a platform for Scotland. So this could be, you put this in, this could start to deliver the whole piece on Telecare and other services for Scotland. We're starting to deploy these solutions in small pockets in the UK. So, actually, I'm going to the wrong slide. So, a little bit more about damming it all down before I finish. So, we've got a fractured and silo approach currently. We alluded to it. We've got the Telecare platforms that live in isolation. They work over the analogue telephone network. We have traditional telehealth technology, again, that works over mobile or the analogue network. The two don't talk to each other. You don't share the information or the data. So the fact that Mrs Smith may well be on something that's maybe helping her blood or a balance, so we've got that. The fact that we know that the Telecare sensor is telling us that she's moving around the house, those two bits of information don't link. So if you start to link it, you can start to predict a little bit more that Mrs Smith is the likelihood that she might fall because of the medication that she's on. Telemedicine. What we don't do is we don't, again, allow the three to talk to each other. Why is it important? So you do a telemedicine consultation, the most important thing is you record it and you store it. That's then part of your medical record history. There'll be information in there that will relate to the other three technologies. And then more importantly is you start to look at the back office systems. So you've got alert receiving centres, System 1, EMIS systems, care records, bespoke platforms. You're starting to pull those together, but as an overall view, none of that talks. Imagine if all of that talked to each other and you can start to get a single view of your patient. The power of that data, what that will give you is it could say, Mrs. Smith at the moment is living in this way and she's currently taking these services. What we can actually see is in 10 or 15 years' time, Mrs. Smith is likely to have a cost of X and the likely outcomes of her life cycle will be A, B and C. So potentially could you start to redirect funding into the correct areas to support that individual. So it's much richer data what we're really looking at the back of it. And again, we start to look at the platform of the future. What could it look like? So, it's not telecare, Internet of Health we'll call it for the moment, Internet of Things Healthcare, whatever it is, it's going to be something different, it has to be. And why does it have to be a restrictive device that only talks to a specific alert receiving centre and that's all it will talk? It can't be like that. You've got to open that up to say each individual device will be specific to somebody's needs. It's about choice. It's about giving people a dignified life at the end of the day and they can choose things. So we're doing interesting things around, you'll hear of technology called Zigbee and Z-Wave, where we're getting, rather than having a great big obtrusive PIR sensor in the corner in somebody in their learning difficulties apartment, we've got tiny little PIR sensors that are built into the fabric of the building. So it's starting to build the intelligence in and look at the product slightly differently. We talk about telehealth, the traditional blood glucose, weight. Digital tattoos are now being built into this. Smart wound dressings. All these technologies are now starting to come into this portfolio. Telemedicine. Enterprise grade telemedicine platforms and platforms that are simple for people to use. The biggest problem with telemedicine is it's very, very difficult to actually connect a session. You just need the ability to send one information piece, you click one button, you're in that waiting room ready to go. Applications. So I'll talk a little bit in a minute about an application that we've built that works on that, but if you looked at our tablets, we have the ability to build apps on there now that allow us to do medical reminders, prescription, reordering. There's a whole raft of things, and these things don't take, these can be developed in about a month. £5,000-6,000 you develop an app after app that'll help an individual. And then we start looking at security, so we've got things like Tom's chaperone devices, visible cameras. We're starting to deploy cameras in certainly learning difficulties to allow individuals to, first of all, have an independent life, which is one good thing, but also reduce the amount of care that's needed. So that we're starting out in care homes as well. We've got a huge problem, certainly in East England, with a lot of abuse going on in care homes. Why should we put secret cameras in care homes? Why should it not be standard? CQC say, let's get a camera in there. And it should be your choice that your parents are in there and that you can actually sign up and say, I want to watch them securely and what's going on. We've talked about the infrastructure. You can't deliver any of this without the IP infrastructure and the digital inclusion piece. But where it starts to happen is then you start to build a platform. So you've got the Telecare platform in the cloud at the top that takes all the alerts from the Internet of Things and Health and from the telemedicine. For digital technology to work, you need to have a means to make calls on it. So you need a powerful telephone system, basically, to do it. And it needs to be a carrier-grade system that is basically, it delivers blue light services, and that's the type of platform we've put in. So you can't just put a cheap little telephone system in there and hope it will all work. Telemedicine platform in there. Next door, you've seen Tom's Communications platform. That is a platform that could basically take every single alert from the whole of Scotland into that alert receiving centre and manage that. It could also potentially scale to become a telehealth centre. So that's the potential you've got. It is the only platform that is cloud-based that delivers this type of service in the UK. So you've got something there that is leading the way, and it's not being harnessed in the way it should be. And then we've got the app development platform. So these all sit there. What we do is we integrate them, we bring them together, we bind them together. That gives us that platform that allows all the services to work. EMIS, System 1, traditional telemedicine, family and carers all live at the other side. What we've got to do is work in maybe the digital platform that you talk about is there's this middleware platform. There's something that binds all this together and starts to give us that end-to-end service, so that you can bring all these services in, all these other services, and when I talk about you get a single view of your patient, that is ultimately what you're going to do, and it'll make it much easier to start planning and predicting what is going on. I just want to just focus in probably more on the applications, and it's a simple little evidence base of using digital technology to transform a certain service. So what it basically is, Professor Ian Phillips has developed a set of questions, 49 questions, 7 pillars that look at everything from mental health, financial, pain, so high level questions. It's currently out in China, Holland, India, and it's on paper. So people go out and do a paper assessment. Fantastic. What we did is we worked with that, and we actually now digitise that assessment. And what happens is we work with a GP practice, and the GP writes out to a cohort of patients, and we then make an outbound telephone call to those individuals to actually say, would you like to take part in this survey? We conduct the survey, and we get the results of that survey, okay? And what we then also do as part of that community is we work with that community to actually find out what are the actual community services and health services that are available in that community, and we build a navigation signposting service behind it. So what that basically allows is we speak to Mrs. Smith, and she says, I'm really struggling with bodily pain, which is one of the big outcomes. And what we did is we referred them to the body pain clinic in Hull, in the Hull Royal Infirmary. What that was happening is there was travel happening, and then people going into the hospital to have the body pain clinic. What subsequently happened is that they then reopened the body pain clinic in Bridlington that wasn't there, which meant that you were getting natural services delivered locally and reopening and signposting. That was one of the outcomes. The unexpected outcome is that out of the first 1,000 people we surveyed, about 250 of them weren't receiving the correct social care allowance or pensions. What that transpired to is that there's £250,000, £250,000 was put back into Bridlington, into those individuals out the back of that work. What that ultimately meant is potentially people can feed themselves slightly better, they can actually heat their homes, could they possibly even pay for some of the services we're talking about? So does that give that, is that cash cow that allows us to do that? So some really positive outcomes out the back of it. What I'm going to do in a second is run a video that basically shows you what actually happened, some of the outcomes off the back of there. So, bear with me a second, a chance to have a quick look at this.
The Better Care programme is all about integration, so it's about working better across partners. And one of the key objectives of Better Care is about promoting self-care, self-management, supporting people into independent living.
So we were invited to become involved with the Easy Care project by our local CCG about 18 months or so ago now. We've got a lot of elderly patients in Bridlington, and this seemed a great opportunity to appreciate some of the needs that they have, which we weren't maybe picking up on with our conventional medical model.
So this is about ensuring that we're working from that preventative angle, and this is about ensuring that actually we're delivering the best possible outcomes for and with local people, and also starting to understand their needs from their perspective a little bit more.
So on your 75th birthday, around your 75th birthday, you will be contacted by the Safe at Home team by telephone, who will deliver this 49 question conversation.
Of the 3,300 letters originally issued, we received just over 1,600 opt-in records back into the contact centre. We achieved almost 100%, 98% we actually contacted, which is unheard of in this industry.
We carried out the assessment. His health and care was actually pretty well covered. Obviously the assessment poses the question, what is your main concern?
I got questions answered straight away. And if they couldn't help me straight away, they said they would put me in touch with whoever I should be speaking to.
People go to see their GP, but they go to the GP for a medical reason. They're not going there to ask advice about maybe a wellbeing issue or a social issue. We always say to you, if there's anything that you need, just ask us and we can help you.
I said, well, I've got an out-of-date central heating system, and that was discussed at length. And that's how I ended up getting the grant.
They were saying things like, I'm lonely and I'd like more involvement with people my own age and with groups. They were saying, I've got aches and pains, but I don't particularly want drugs for them. I want exercise class, I want to go dancing, I want to have some activity to help with my pain rather than more drugs.
They put me in touch with health traders in Bridlington, and I lost 2.5 stone.
For me, one of the most powerful things that came out of this piece of work was the amount of money that we were able to draw down for these individuals. So in excess of £250,000, £250,000 that's been brought into East Riding, that's supporting some of our most vulnerable people, that's starting to have a real impact in terms of their quality of life.
The feedback that we receive from patients is invaluable, and we can gather that very quickly, and we can gather it in such a way that we can use it to improve future services that we provide for EasyCare.
I think we've got some really great information from doing this, and we've made a real benefit for people, and we've had great satisfaction from the people who are involved. It actually usefully identified some gaps in services that we can do something about, but it didn't create a flood of need, and that can be a concern when people are trying to manage resources.
As you can see from the initial analysis of the work within Bridlington, the return that we've got to the local community is in excess of the financial resource that we put into funding the scheme.
This is about social care and about social provision and about building up the resilience of the community. I still see the patients. I see from their records that they've had the Easy Care assessment, and I still have to treat their blood pressure, their diabetes, things like that. I still have a chat about their bereavement and about their sadness and loneliness, but I know that we've got other things to treat them with.
Summing up the work, it's been a really important element of our journey in terms of integrating health and social care services, and that actually services need to move towards more of the enabler aspect in terms of supporting them to be able to continue to live healthy and independently for as long as possible.
The partnership approach that's been involved in this has been really excellent. It's built some enduring relationships, as well as actually giving us some really good measurable outcomes. I think I can say we'd certainly recommend it.
Generally, they're looking after your well-being, really. But you need roughly who to get in touch with to guide you in the right direction. If there's some sort of help, whether it's financial or practical, accept it.
So just one example of where we used it. Where that goes next, hopefully the whole of East Yorkshire, 32,000 people will survey. Heart of England, 500,000 people in a survey. Could you do it in Scotland? Could you actually speak to everybody in Scotland and actually start to build that data? So that's where we see that going. That's a very simple tool. So that's kind of the end of the presentation. What I wanted to really do was just kind of like start to have a little bit of a dialogue around, we can deliver technology, people can deliver the strategy. Most of the people in this room are the people that potentially need to have the ambition and take this and deliver it. How do you foresee the vision that was shared next door, some of the things I've talked about actually being delivered at scale across Scotland? So it's kind of like an open question, but it's just good to get a debate going around, do you see barriers, what are the barriers, what are the problems to doing this?
I think there would be a lot of discussion around some of the potential civil liberties questions that were indicated in your presentation. Yeah. Like listening devices in your home.
Yes, yeah.
Like, and also you I mean, maybe it's a south of the border thing, but I don't see any appetite here, politically or otherwise, for charging people for accessing digital health. It would increase the gap, the inequality gap, to an unacceptable extent north of the border. So I think for me, those are two very culturally different points that you raised. The rest of it, obviously, is, makes good sense.
So just, I think the piece around the acoustic and seismic listening, that's kind of like, it will, that type of technology will happen. It's already out there. And I absolutely agree.
But there needs to be a discussion with people. You've got to know that that's happening, haven't you? Otherwise, I think into really dodgy, dangerous territory.
No, I agree. I think you probably. I'm not saying that it's. That's what we're testing and trialing at the moment. That's what we're trying. It's not that we're going to all of a sudden start listening to all the fibre optics in the ground. That certainly won't happen. But it's just kind of like showing to you in the innovation what the potential is of technology. That's where it could go. And you're exactly right. It's how do we how do we make that fit the purpose and keep
Well,
it
it's got to be
secure?
acceptable to people,
Correct.
and that comes back to Zaid Dean's point about you've got to do stuff that people want.
Yes.
You're not imposing stuff that makes your life easier and generates income from you by listening to me. Thanks very much. Not going to happen.
Interesting. Okay. And then the other piece is about the financial piece. I kind of like I didn't.
No,
I missed that. I
Scots in the room.
So I guess for the 42% that don't have broadband currently, how are they going to pay for that? That's kind of like where I'm coming from. Is I presume they're going to have to go to. They're not going to get it for free, are they? I presume people pay BT or everyone a subscription, a monthly subscription, £360 a year for a broadband service.
What's talking about your presentation was just the example. You can create a divide there if you don't get the policy around this right. The future look at robots in the house and all that, and enabling that in the house. Actually, it could well be that an individual does that, pays for that for their mother or father.
Yes.
You see what we mean. Hence, there's a consumer market there. But whether the state has the wherewithal to meet that demand is a real question.
And I think that's why I
Penny's right. Our principle is that health, health care is free at the point of service. So.
And if there's going to be enormous benefits for individuals to keep them at home, then why wouldn't a system that's spending enormous amounts of money on bringing them into hospital transfer that resource and put it into the home?
Yeah.
And that's certainly the Swedish model. We just had a presentation
Yes.
on what they were doing in Sweden. They had identified broadband in some areas, or a roaming SIM, and that was supplied with the Telecard equipment to digitalise and enable.
Absolutely.
So therefore, that manages that demand.
But I guess where I was coming is people are still going to have to pay somehow, whether it's a mobile SIM or whether it's a broadband connection. They're still going to have to pay for that.
I think that
to a service.
social care or health as well. Because obviously, where we're from, in social care, people do have to pay for them services unless they meet critical or they have a personal budget. Health is completely different because it's free at the point of service.
But they're not unconnected.
Now you start to bring them together, yes.
They're not unconnected.
I'm not that technically savvy, right?
Yeah.
But you haven't actually addressed any vulnerability. If a lot of these products are cloud-based, right? Where's the security to stop somebody hacking through to either your record or through a piece of kit and changing the parameters and stuff like that?
So and you actually, the diagrams we put there, we don't go down to a low-level design, it's a very high-level imagery that we show you, but you're absolutely right, the type of infrastructure that we put in place, the encryption and the software and the firewalls are in place to stop all of that. But if someone
what
answers...
you're saying there, but people are hacking into the Pentagon and stuff like that. Not saying they want to get into anybody's client record, but I just see a vulnerability in this.
But you can bank online. You can protect that.
You can, but I absolutely agree. Is your transformation is around going to digital technology. It's going to happen. It's happening. But if somebody wants to access and tap into that and hack into that, they will do it. Someone will find a way around it. But unfortunately, that movement to IP and digital technology is happening. It will continue to happen. I guess that paradigm shift that we need to make around technology advancement is around the security piece. How do we make things more secure? But I don't think you're ever going to stop it.
And also, there's risks we run anyway that we're not aware of. I mean, hospitals are really dangerous places to go into. Do people know that? No. Do you know what I mean? We take risk, and actually, personally, I think we ought to be a lot less risk averse about facilitating this. But obviously cognizant of people's individual liberties, for me, that's a different issue.
Okay. Right. Yeah,
I think it's an interesting point about the kit, if you like, because we're working with people with dementia, part of the tech fund, and we are producing iPads, just typical kit you can buy in the shops, and people are using them in various ways, communication and finding information, etc. And they're really enjoying using them in the families as well. But the question is, we're using them as a kind of loan facility to introduce that technology, and it's like we cannot provide everyone with iPads, but we can enable them to possibly encourage them to buy their own kit. And is that a health?
I think if that increases inequality, I think if that means that if you are poor, you don't get access to those services, I see a real problem there. And then, so why not? The kit is actually quite cheap. Why can't we give people
look at
kit?
recycling kit or smart
Well,
TVs. It's the sort of stuff that people buy as well for leisure that can have a health and social care benefit. So it's partly they can use some of this kit for their, like to watch TV, but they can possibly use it with the right technology to access health information or to do a health consultation somehow. So is that, it's kind of like who purchases the kit and what is the kit for? It can be for a wide range of things, not just health and social care.
I'm just going to say who maintains the kit, who's responsible for the kit.
It stops you from taking it down to the pub and flogging it on a Friday night when you're on.
Tons of
It kind of goes back to that joined up approach there. Is potentially what is happening is people are getting a telehealth device, and they're ending up with 5 or 6 devices. And they won't use them. They'll stop using it.
I think in terms of the technology care programme within Scotland, I think we're very cognizant of that. So the work streams are beginning to emerge, and we've got exemplars that we're working towards health and social care that sit around the individual. And so that's actually something that will start emerging naturally as we go forward. But yeah, we need to test that out.
Yes. I was just going to add, I think the idea of combining the sort of telecare with a digital platform coming through the same box in the house and your smart TV, it just makes sense.
My view is clearly with this, because it is ideally to work from the inside out as well as the outside in. We should just use there is an opportunity here to now address common platforms, to address common services. You alluded to that. It was interesting, the Swedish presentation where they're very oriented in Scandinavian countries, as we know, to the municipality delivery mechanism. So they're what was it, 240 odd municipalities. Their own decision, but they were doing it according to a standard. If you see what I mean. So
that's critical.
And I do think we've got time. I mean, I know that our telecom providers are pushing Ofcom, but Ofcom do continue to provide an analogue service, and there's no switch off point being announced. It has not been announced. It might help if there was, but actually at the moment, we are working towards, that it will be, but it's not been announced yet.
Yes.
So it gives us planned time to make the best of our services as we redesign them going forward.
Thank you.
Brilliant.
Okay, thanks.